Hello, my name is Amy Guerin with Healthcare Dive. I'd like to welcome everyone to our webinar, Nurse Engagement Matters, Improving Patient Care by Transforming the Nurse Working Environment. Today's webinar will explore how healthcare organizations create a work environment that drives nurse engagement. We'll hear from two industry experts, Tonkin and Corning of Cornerstone OnDemand. They'll discuss the myriad of issues affecting nurse engagement today. Our speakers will address key questions on the topic, focusing on how to improve nurse engagement and what a transformation of the nursing work environment could do to drive engagement. Before we get started, I have a few housekeeping items. If you have questions, please send them to our speakers during this webinar using the Q&A box on your screen. We'll answer a few questions at the end of the webinar. Answers to any remaining questions will be sent to you later by email. We'll also send an email with instructions for accessing the on-demand recording of today's webinar. Now, I'd like to introduce our speakers. First, we have Tonkin, Principal, Change Management and Transformation Thought Leadership and Advisory Services with Cornerstone OnDemand. Also with us is Corning, Healthcare Specialist at Cornerstone OnDemand. Tom, I'll pass it over to you.
Thank you, Amy, and good morning, good afternoon, and hopefully some good evening, folks, if we are on the internet, and hopefully it's global. Really appreciate everybody's time that you've taken to log in and to listen to what we have to say. We're actually very excited about this. This is a conversation that is very passionate for myself and for Christine. Again, my name is Tonkin, and alongside me here virtually is Corning, better known as Dr. Tom and Nurse Christine. Christine, you want to say hi?
Hello, everybody. Thank you for joining us today.
Excellent. I don't think I really have to spend a lot of time telling all of you the challenges that healthcare is going through in the year 2017 specifically. There's a whole bunch of new policies that are coming from the old administration into the new administration, really still up in the air. And you know how this all works. It just rolls downhill, and you still have to provide the high level of quality and care that everybody's looking for. But today, we're going to focus specifically on nursing and what nurses can do, some of the challenges they're going through, and some of the things we can do to mitigate those challenges, revolving around engagement. We personally believe there might be some misalignments that we have to consider, and those misalignments are the things that actually inhibit good performance, at least a fighting chance, if you will, on the floor. There is a tremendous amount of statistics, and one that I just want to highlight here to provide the realities of what we're talking about. There's a great study that came out in 2002 out of the Journal of American Medical Association, and it suggests that there's a 7% increase of a patient dying for every additional patient in a particular nurse has in their workload. That same patient also has provides, if you will, for lack of a better term, an increase of 23% of burnout, additional burnout for that nurse. So you've sort of got to coming and going. And so I think it's incumbent of us as healthcare leaders, healthcare professionals, as well as those that enable that healthcare profession to serve, to come up with some better ideas to help the situation. We're going to touch specifically around this idea of performance management and development for nurses. So we got to understand the healthcare environment. We are shifting, right? We're shifting from a standard provision of services to outcome-based. And there's lots of things in flux. Needless to say, this is an external factor that we need to understand, and we'll get into the level of detail here in a second. I think it's important not only that we understand those external factors, but how those external factors then influence the challenges that nurses have. There's an interesting article that came out about a year ago or so talking about the actual flux in specifically the nursing industry. There's a gentleman, his name is Ron Moore, retired actually this October out of the West Virginia Charleston area medical center. And he talks about this is probably sort of the worst nursing shortage that he has seen in the last 40 years. And he's been in this business for that long. So it'll be very interesting for us to see what can we do different, because we've been talking about this nursing shortage thing for, as well, you'll see here in a second, for quite some time. And I want to boil it down to the fact that the nursing shortage issue, I'm going to make a big statement here, is really a social issue. And once we understand what those social issues are, maybe we can find some opportunity for us to increase our opportunities to solve some of those nursing shortage issues. So let's get to it. So I think the first thing that I want to address is this idea of the nursing shortage. What it really is, it's really a nursing educator shortage that actually trickles down to the lack of practicing nurses. The fact here is that we have a problem or a situation where we just don't have enough educators to certify and to train good nurses to go out and practice. It's interesting, as early, or should I say as late as 2014, we had to turn away 70,000 nursing applicants, not because they weren't qualified, there was no place for them to actually be trained. And so we tend to say that there's this nursing shortage, but what we really have is actually a nursing shortage, educator shortage. And what I want to do for the next few minutes is I want to give you a timeline of how this has been addressed in the social realm. So we got to go back to World War I. And in World War I, what happened, of course, is we've got soldiers fighting the war. They're coming back. They need to be cared, and it was arguably a big hump of need for nursing care. So what happened was we got some nurses' aides in place, we've got some volunteers, and we're able to sort of shore that up. Same thing happened again in World War II. And to the point that in World War II, we actually had to find another 12,000 nurses, aides volunteering in military hospitals to deal with it. So again, the reason I go back to all of this is because this is very much of a nursing shortage issue, meaning you have these external factors such as a war or other things that are going on that presses on that issue. It wasn't until 1987 that Ronald Reagan actually passed what was called the Omnibus Reconciliation Act, which standardized certified nursing assistant training. This is basically what we now know as CNAs. And in essence, what we felt was one of the reasons that we can actually sort of shore this up a little bit is our ability to provide staff quicker at a lower level, but yet be able to stretch out those that have that expertise, such as nurses. So, for example, I'll just make this up. If there's 15 nurses, a need, if you will, maybe I can get away with, 10 nurses and 10 CNAs. And that was the strategy back in 1987 because this continuing shortage of nurses. I want to turn it over now to Christine as we fast forward into the mid to late 90s and have her give us a sort of on-the-ground description of what was going on with that. Christine, what do you have to say about this ongoing timeline of issues?
Yeah, so it's something we've been discussing for a very long time. As a matter of fact, I graduated from nursing school, totally going to date myself now, in 1996. And when I got out of school and passed my exams, I was unable to find a position in an inpatient setting. So I had to find a position within a long-term care facility, which was great. I got a lot of good experience there, and really wait a year until I was able to find a position within a large metropolitan hospital. And at that time, the reason there were very few RNs being hired is that because they were supplementing the staff with certified nursing assistants or patient technologists or whatever the label was at the time. I was fortunate that I was hired by Beth Israel in Boston under the guidance of Dr. Joyce Clifford, who was the CNO at the time, and she was kind of going opposite the trend. She had pioneered the primary nursing philosophy. She didn't develop it, but she definitely pushed it into the metropolitan hospitals. And what that was is, instead of having, individual CNAs or functional folks taking care of these patients, she really truly believed that having a BSN-prepared RN assigned to a patient as a primary caregiver was going to increase the quality of care and decrease the increase nurse retention, and it worked. So we had a very high retention rate. We had great quality outcomes at Beth Israel, and it was really opposite what everybody in the industry was doing. So, I think it was prior to this entire discussion around engagement, but it was ahead of its time, but it did prove that having a team approach where you have 5 or 6 folks on a team being overseen by one nurse who's putting the patient at the center really does lead to better quality care. Also, if you look at that functional care model with the CNAs, you have folks going into the room to take care of patients, but they're going in task-oriented. They're going in to change a catheter or to going in to check vital signs or help with activities of daily living. And it's not really looking at the patient as a whole. They're not able to use any critical thinking skills or assessment skills to identify how the patient is truly doing, and you miss a lot, and that's where that quality can really fall off. So I think, Dr. Joyce Clifford was definitely ahead of herself. As a matter of fact, I read an article about her in the New York Times upon her passing. So this was 6 years ago now. And they summed it up nice. It said the idea was to restore the continuity and accountability that were considered casualty of the nursing system then, widely in use, this functional nursing system. So in the team system, each nurse had a specialized task, but no single nurse had a glimpse of the big picture. And I think, Tom, that is the piece that was missing. Having all those bachelorette-prepared nurses as primary caregivers at Beth Israel definitely led to higher outcomes, improved outcomes, and increased retention rates.
Which is very interesting, because what you've described really now, and to your point, she was ahead of her time, because we certainly could use a little more of that. The outcome aspects of nursing really weren't mandated back in those days, as they are now and will continue to be, as opposed to just providing services. And so I find that fascinating that somehow sort of didn't stick, or how that. Do you have any idea of the trajectory of where we are with that?
Yeah, actually, we are headed in that direction, and I think things like the magnet journey that organizations are on, as well as the shift to value-based purchasing, has really pushed the issue of having to have BSN-prepared nurses hired and maintained on staff. Now, going back to your original point, if there's not enough educators to prepare these nurses, now we're really getting into this vortex of this shortage, and I think that's a big problem. As a matter of fact, my alma mater, where I graduated in '96, only took 1 in 14 applicants this year for the nursing program. So there's definitely a shortage in the availability of that education, yet there's a mandate to have these BSN-prepared nurses in all of the organizations.
Yeah, you make an excellent point. And the thing I want to go back to, what I said earlier, was that you say 1 out of 14. Arguably, most of those were probably still pretty qualified to attend. So it's the whole supply and demand, where if I know that I'm not going to be able to service a student, I'm just basically going to take the top students, if you will, whatever the metric may be, knowing that many of those 13, if you will, that aren't going to get accepted certainly are qualified.
Exactly. And I think, there's definitely a lot of push for the LPNs and the associate prepared nurses to move towards their BSN. But again, are the classes available? Are the courses available? And the instructors, most importantly, are they available to provide this education?
That's an excellent point. I want to move on, because I'm very conscientious of time. You can see how we can get into some great detail here. But suffice it to say here in summary is that we have a nursing educator shortage that trickles down to the overall nursing challenges. Most of this is socially driven by, in this case, the lack of or should I say the increased amount of need for nurses in this case. We're talking about World War now. We're going to be talking a little bit about the fact that our population continues to get older and requires greater levels of service. And so what are some of those issues that there's a number of issues as it pertains to staffing nurses compared to the work required from a regulatory perspective. And so one of the challenges one of the solutions for this challenge was that of saying, well, is there a different level of service that we can provide? And that, again, that's the CNA angle that we've taken in this talk track. Another challenge here, when you then introduce the CNA issue, which was very interesting. I was talking to a director of recruiting actually at a facility in South Dakota. And because the changes in compensation, and I'm talking about specifically outside of healthcare, meaning the minimum wage is increasing, there's all sorts of extra benefits, we now see people like companies like Walmart actually competing for that same pool of people that would potentially be CNAs. So we have this wage discrepancy that's currently going on. So in essence, they have other career options. The demand of the result of the aging population. There's a host of other things that I like to talk about, but I want to bring Christine back into this discussion because when you were in the field, right? So there was a time where the CNA sort of extra type of help worked. You had a hard time, or should I say, not an easy time finding a job because that for that period of time worked. But now as you move forward and you found a job and all of a sudden you found yourself being overworked, what do you see currently now as it pertains to the amount of pressure and regulations placed upon nurses to be able to actually satisfy an outcome-based approach?
Yeah, so, I'm sure the entire audience is aware of all the various quality outcomes that they have to track. I mean, whether it's CMS, AHRQ, CQI, NQI, I could just make up letters. There's just tons and tons of various outcome measures that need to be met. Many of them overlap. And these nurses are being asked to not only care for their patients, but also to keep an eye on the documentation to maintain the analytics around these quality outcomes. The organizations are well aware that they're going to be reimbursed less for patients that are readmitted or patients that acquire any kind of conditions within the hospital environment. So there's an awful lot of pressure on these nurses to provide care under very stringent guidelines, which takes a little bit away from the art of nursing and the science of nursing and puts you more in an analytic frame of mind, which is, in my experience, is not why nurses go to school. They go to school because they want to come out and they want to take care of patients and they want to provide care to the patient and their family. When you get to the point where you are spending most of your time documenting care but really documenting for effect for analytics, it takes away from that time at the bedside and that time really providing compassionate care. So I think there is an awful lot of pressure on nurses in that regard. There are some that do it very, very well, and I think you and I will probably talk about this a bit down the road here. We need to start to recognize those folks a little bit more and to build a model around their ability to provide that care.
Yeah, you mentioned that. I forgot to really bring that up earlier where so there's this shortage of nurses, and shortage of nurse educators. And we know that the nursing profession is very much one that understands that those nurses have to teach other nurses as they grow up, but they want to do that on the floor, right? They don't want to do it in a classroom. And so it's the same thing here where what is and we'll talk about this a little later, the intrinsic versus extrinsic motivations of nurses and why they get in the profession. They for the glory and the fame and the riches as well as the money, right? So, and I say that facetiously, but having to understand that perspective, and therefore we're able to help on the engagement, right? This is the theme that I want to move forward on, and we now go to the next sort of opportunity from a strategy to stretch the population of nurses to service is that of the idea of specialists. So we talk about the notion that we want to move forward and say, well, maybe there's a way to service all of these folks, these patients that we're getting, if we start looking at nurses in a specialty program. So, right, so we not only do we have maybe specific diseases or care, but we also have functional specialists. Like, for example, my wife just underwent a total reverse shoulder replacement and had the opportunity to, about a week ago, this has happened, and we went through the hospital, and I took her to the hospital, and of course, being the researcher that I am, I started knowing all the nurses and asking them all sorts of questions to see how their engagement is going. But it was very interesting because first I met Tara. She was the pre and post-op nurse, and so she took care of my wife at those levels. And then the OR nurse came in, and so she talked about that. And then the OR and the pre-op nurse started exchanging information. And it wasn't until my wife was then admitted into the hospital, she had to spend the night, and then a new set of nurses came on, and then you had the shift issue. So you have these generalists as it pertains to shifts. You've got these specialists. I want to, Christine, we have all these different groups, right? We tried the CNA thing. It worked for a little bit, maybe not so much now. We've proven that we need something more. We moved to specialists. I know you have some background on some specialty stuff. How did that work then, and how does it work today?
Well, I think, what you're really describing is the transition of care. So anytime there's any transition of care, whether it's between providers or physically moving the patient, there's always the opportunity for error or miss. And that's been a real big problem in nursing for as long as I've been aware of it. So what needs to happen is that collaboration piece really needs to be tightened and really needs to, I think there's some efforts in that in the EMR push where if we're all on an integrated system, we'll be able to have information at our fingertips, which is great as long as you're looking at the computer screen. It's not going to talk to you. So we need to make sure that folks are actually looking at the information that's available to them, that organizations are providing easy means of seeing information and sharing information. I can't tell you how many committees I was on where we had some fantastic ideas, how, wound care committees and fall risk committees, but they don't go anywhere unless that communication is out to the rest of the nursing staff. So having that collaboration within the nursing groups is a key to quality care, whether that's at the transfer of patients or whether it's with key initiatives within the organizations. We need to make that easy and much more abundant in these organizations because they are large and disjointed organizations. They've come together through merger and acquisition to form an ACO, so there's multiple hospitals under one umbrella now, but we need to have a continuity of care across the entire organization so that you have a clear and concise message for your patient so that your patient has confidence in the care that they're receiving and you're able to share and collaborate as professionals within the nursing profession and share and advance the practice to the point where there is less transition issues or less perhaps injury happening at that point of transition. So I think collaboration is key. However you do that, whether it's with technology, quite honestly, some of the best collaboration I've seen in the back end, we had a paper cardex that just got passed from person to person to make sure that the communication was happening. Obviously, that's not ideal. We don't want to use paper anymore. But making sure that things are updated, that notes are updated, and that collaboration continues as the patient moves throughout the continuity of care or the continuum of care is very, very important. Some of the best information I received when I worked at large metropolitan hospitals was from the float nurses because they worked in every department. So they learned in each department what the best practice, and shared that throughout the organization. And it was very informal. That was not a formal process whatsoever, but that's some of the best information that we got.
What a great opportunity it would have been if we had elevated our float nurses to something where a status, right, where they could be recognized as ones that may have that skill. And again, we're going to talk a little bit about that elevation that goes with it. But before I move off of this topic, I want to reintroduce the idea of this functional teams versus team nursing. And because, right, that's one way to collaborate is you sort of create these teams or these groups, if you will. And obviously one could be patient-centric or one could be process-centric as it pertains to nursing. What have you seen as it pertains to nurse engagement across those different groupings?
So it's funny so if you had asked me that 2 weeks ago, I would have had a different answer. But I was able to attend a healthcare-specific workshop just recently, and the keynote really caught my eye. Cy Wakeman, who is the author of No Ego and has a firm that has done reality-based leadership research, really made some great points around engagement. Engagement is a very 2017 word. We hear it every day. But are we talking about making nurses happy, or are we talking about really, truly providing a culture of accountability within our organizations? And I think the latter is where we want to be. So some of Cy's research shows that if you talk to two different groups of nurses and you have a group of very accountable high performers and you have a group of let's call them taskmasters, for lack of a better word, and you ask the same question, what can we do to make your life better here at the organization, you're going to get very different answers. From one group, you're going to hear things like, if the pharmaceutical reps bring in lunch, we want to make sure there's enough for the nurses, or can you pay for our scrubs, or can we have in-house daycare? All wonderful things that will definitely increase the level of satisfaction of the nurses, but does it really increase accountability? From the other group, you're more likely to get answers such as, we really need to fix the printer because our discharge instructions are getting smudged and we're afraid that patients are not going to understand their medication schedule and there could be some errors there. Or let's change the visitation hours so that patients can spend more time with their families, which is proven to show that the healing process will increase and also decrease stress on the family. Those are obviously very patient-centric answers, and I think that those nurses, those ones that show that accountability, that show that true compassion for their patients, are the ones that we want to build models around, and we want to have, celebrate them and make sure they're known, provide recognition, so that the other nurses can then work to be, that particular high performer. And I think that's the route we have to go. Providing lunch and breakfast and lollipops is great, but you really need to make sure that you're striving for a culture of accountability as opposed to, I'm listening to you, tell me what I can do to make you happy. That's really not going to get you anything but a bunch of venting nurses.
Yeah. No, you make a good point, and it's probably not something that would be intuitive as we have this conversation. So I want to take a minute here and kind of pivot our conversation. So for the last 20 minutes or so, everybody in the audience has been listening to you and I talk about all the issues. And I think everybody's now appropriately depressed about all the challenges that we have. And here we are in the webinar, and we're here to help solve those. So I think we've created the weight of the world on this particular problem. And I want to pivot at this point and start talking about some of the areas that we can help this along. Now, mind you, there's probably a whole bunch of different things that we can talk about, as you can imagine. But in this case, what I really want to focus on are in essence, two areas. So I want to talk about how can we properly assess skills and competencies, and what are the right skills and competencies to have that will motivate engagement, and of course, what are the extra areas of motivation for those particular nurses to increase their engagement, hence their quality, and so on. And so in this case, I think we probably can again be inundated with all sorts of assessments, competency discussions, and all that comes with it. Christine, I want to know, and so do the people in this room, right? We want to know what are the essential skills that will do two things: provide the quality of care that I want as a nurse, and number two, how am I going to feel fulfilled and engage in that position?
Well, I think first we need to identify the difference between a skill and a competency, right? A skill is I've watched somebody do something, whether it's insert an IV or hang a blood product, whatever it is, check them off, and yes, they are able to provide that skill. Competency, when you talk about competency, there's more around compassion of care, ability to provide a positive patient experience, the ability to really meet the professional goals of their role. So I think there's a big difference there, and we oftentimes lump them together. I also feel like sometimes we do skill and competency assessments just to meet a requirement, whether that's a DPH or a Joint Commission requirement. We're really not doing it in the effort to improve the performance of our nurses. And I think the competency, and I've talked to a lot of large organizations recently, that are starting to move their mindset to this needs to be an ongoing and continuous conversation. It's not once a year, let's talk about what your competencies were this year, how you did, oh, you're a 4, great, next year hopefully you'll be a 4.5. That's not a true competency assessment. We really need to have conversations on an ongoing basis, making sure that our professional nurses are meeting the standards of the care they're providing to their patients, and not just at a functional level, but truly accountable for their actions, elevating the culture of the organization and making sure that it is positive in all ways. And that's not going to happen with a check-in once a year.
Yeah, I want to go down this path, and I'm going to encourage our audience to pull out a piece of paper, pencil, or some electronic means to capture the next few minutes. I want to go back, Christine, to challenging you on this discussion around accountability. Mm-hmm. So if we were to look at accountability outside of a personal trait to more as a competency, I know that there are a few areas for developing accountability that potentially may help engagement. Can we review some of those and give the audience some insight?
Again, to give credit where credit is due, this is from the reality-based leadership research that Cy Wakeman did in her book, No Ego, and I highly recommend that the audience read this. It's a very interesting read and I think very relevant today. But really, she talks about the 4 factors of personal accountability, and you really need to measure commitment, so the willingness to do what it takes to get the results you need, resilience. So as nurses, for those of you who are nurses in the audience, you have to be very resilient. It's a highly emotional job. You are dealing with life and death on a daily basis, and it's not just go in, punch the clock, do your 8 hours, and go home. It's with you all the time, 24 hours a day. And I think that the ability to maintain calm, to be purposeful and confident in their abilities is essential in that resilience piece. Ownership, taking ownership of the care that you're providing is huge. It's not my problem is not a sentence that can ever be said in the world of nursing. So I think it's very important that ownership is a core value within the organization, and obviously continuous learning. This is an ever-growing art and science, and we have to make sure that we're on the forefront of what's happening in the industry, best practice, in learning from our peers, learning from industry experts, and just continuing to grow and learn as a professional nurse. So I think those 4 pieces, I agree with Cy, in that they're very important in developing accountability within the organization and within each employee.
Okay, so I'm going to go ahead and summarize, right? So we have commitment, resilience, ownership, and continuous learning as areas that potentially all of you can start looking and reflecting on. We'll give you a call to action here later on the webinar, and I have a few thoughts. I think from a resilience perspective, you're correct. It so happens that in my family, I have nurses and doctors all over the place. My mother-in-law was a phenomenal oncology nurse, and you're absolutely correct. She used to bring all of that with her. And as an oncology nurse back in the 70s, that was a challenge, to say the least, as far as survival rates. And so it really sort of cuts to the bone as to what it is that nurses have come for. And I think it's important for us to continue to bring those up as those that are learning and development leaders in this space, or leaders of any kind, to make sure that we address these 4 issues that nurses are deal with on an everyday basis. The aspect of continuous learning too. I'm going to do a quick little plug. There's lots of different webinars that I personally, and as well as blog posts that I have written specifically around continuous learning and self-directed learning for other resources that you're looking for, YouTube and other places that you'll be able to find me. So. I can't agree. Those are sort of the two that kind of flash up on my mind. The second thing that I want to talk about as it pertains to engagement with nurses, as it pertains to performance management and development, is the idea of providing the motivation for engagement. Now, what I find fascinating, one of the reasons that I really enjoy working in this field, is that it's very different than many other fields, in the sense that specifically nurses, good nurses, now mind you, it's hard for me to say good nurses versus bad nurses, because I think all nurses are good in the sense that they all get into the profession for the right reason, which is to take care of people, which in essence is very much of an intrinsic motivator. There are two types of motivation, right? There's intrinsic and extrinsic. To be clear, an extrinsic motivator would be pay, would be shift, would be benefits, lunch with the vendor, all that. Where intrinsic motivation would be those things of patient care, the fact that there is a purpose in my work, that I am actually moving society to a better place. And so what we're talking about here is a whole bunch of people that got into the profession to satisfy an intrinsic need that they may have. And yet, as leaders of an organization or as managers or whatever, kind of the only thing we seem to have are extrinsic motivational tools. Better shift, maybe I can get you a few dollars on your paycheck or your hourly rate, whatever it may be. And so I think it's important for us to identify the challenges as well as some of the solutions when it comes down to these two buckets here. So, Christine, you being a nurse, you got in it for intrinsic motivational reasons. Tell me the internal wrestling that you had between these two things as you try to make a living as a nurse.
Yeah, well, I mean, we definitely didn't go into it for the money or for the schedule, because neither are very good. But the reason that most nurses go into nursing is because they want to provide care. However, being recognized goes an awful long way. There were days where I had the absolute worst shift I could possibly have, but then a family member brings flowers or chocolates or just says thank you for taking care of my patient, my father, my mother, whatever it was, and that was nice. But more importantly is when you get recognized by your employer. That definitely puts a little bounce in your step, and it helps you to continue on doing this very grueling work in a very positive way. And motivation doesn't have to come from a shift or from money. It really can be something as simple as being recognized throughout the organization. If perhaps you've put a care plan in place and it really showed to have amazing results for the patient, and having that work recognized by your peers and by your supervisors is huge. We live in a society where we don't play favorites anymore, and I really think we need to start doing that. And by doing that, you're elevating that person to where the rest of the staff should emulate what they do and try to be as good as that person. Make it a bit competitive if you have to. I think that's the best way to go. That's, it does motivate people. And like I said, I think I actually remember I had a situation. This was when I was in long-term care, where my patient who had dementia was smoking on oxygen in her room and set the room on fire, including herself. I had to run into the room, put out the fire, which was interesting because we had fire safety training the day before. And, when it was all said and done, I didn't receive a raise or get a better shift because that happened, but the CEO of the organization brought me flowers, made a big announcement to the whole organization, and it really did make me feel a lot better about what I did. I mean, obviously you can do it anyway if someone's on fire, but it's just having that recognition of a job well done goes a very, very long way.
I think it's funny, right? I think as managers or leaders in an organization or an industry that continues to be pushed towards a bottom line industry. This is the premise that we started 20 minutes ago or whatever, it's been a half hour ago, of how the external forces, the social forces continue to push a healthcare industry into a bottom line, we tend to start acting like bottom line managers and really miss those kinds of opportunities, which cost us nothing to pat somebody on the back or recognize them as such.
No, I think you're right. And of course there are numbers to validate the fact that lack of productivity is associated with disengaged nurses, and Preskini did an excellent study on this where you could identify the cost, and you're looking at about $22,000 per nurse. And yes, there are hard, concrete numbers around that. But how do you measure engagement? Are you really talking about engagement, or are you talking about that accountability piece? And that's where I think we need to start identifying the focus.
That's an excellent segue towards the end here as we close out our thoughts. I am hopeful that everybody that in attendance and those that may be listening on replay that we were able to touch on some salient points. Let me summarize with challenges that we have around the nursing shortage and the challenges that we have externally on this particular industry, and some of the areas that we can improve around understanding truly whether we're looking at competencies versus skills and the associated motivation to move those forward. So let me bring some call to action and some reflection here. I think number one, those that have attended here and jotted down some notes, I would think go back and reflect, especially if you are a full-time working nurse, right? Hopefully we've touched upon some things that made you think twice. I think sometimes we're so busy doing the thing we're supposed to be doing that we don't have an opportunity to reflect. Second, I would suggest that maybe you could apply some of the ideas that myself and Christine have laid out for you. And then lastly, maybe take some of the resources that Christine has put forth and start asking around in your neck of the woods what you can do better. Before I close it out and turn it back over to Amy, Christine, any last thoughts and reflections on what we've been talking about?
No, I think we need to focus as an industry. We need to start focusing on the education piece of this. I uncovered quite a bit at the beginning of our discussion. We're not going to be able to have fully staffed BSN prepared nurses in every hospital in the country if we don't have the educators to provide that education. So I think that's a key point that we need to start looking at. The nurses, not only is the patient population aging, but so is the nursing population, and they are going to age out by 2020. So we really need to start looking at this process of preparing our BSNs and making sure that they're in play, because I don't think there's any argument that that's the best means of care. We need those critical thinking skills and those assessment skills in key areas within the healthcare system. So that, and I think that the discussion around engagement versus accountability is something that we need to start thinking about. And again, to give credit where credit's due, Cy Wakeman really got me thinking about that, and I think it's something that I'd like to do a lot more discussion with my current organizations I work with, and just see what their thoughts are around that. And I'd love to hear some of the thoughts of the folks on the webinar today. So thank you, Tom.
And I certainly appreciate your time, because your thinking got me thinking. So I appreciate that, and hopefully we got everybody else on the call thinking. With no further ado, I'd like to turn it back over to Amy and see if we've got any questions that we could address from the audience.
Well, thanks, Tom and Christine. That was quite an enlightening presentation. Now that we've looked at the many issues surrounding nurse engagement, we have a few minutes left for our speakers to answer some questions. Here's the first one. Christine, I'll toss this to you. Which attributes are most essential to nurse engagement?
Thanks, Amy. I think, again, I think it really comes down to those key areas that we talked about around ownership and resilience, commitment to the organization, and most importantly, that commitment to continue learning and to continue growing within the profession of nursing. And I think that it falls upon the healthcare organizations to provide a means for that continuous learning, for self-development, for the ability, not just to take your mandatory trainings, but to truly have a trajectory within your organization of your career and what you want to do, and make it known to management, and to identify development plans, and to really take ownership of your own training and development within the organization. So I think that's a key piece when it comes to engagement.
Great.
This is Tom. I like to add to that. I like to provide a generalized view. The term engagement is one of those things that I think is sort of industry oriented, and I think it means a lot of things to a lot of different people. I think we can go back to the early 70s, or should I say the late 70s, right? There's a lot of social issues that were addressed in the 70s. One of them was this idea of what are the behaviors that I can find in an organization that actually move an organization forward. Now, this wasn't healthcare oriented. This is just any industry. And basically fell into two buckets, the compliance and the altruistic. The compliance bucket was all based upon what's on my job description, and the altruistic behaviors are stuff that's not on my job description. And those were the two behaviors. And as you can imagine, the high-performing people and the high-performing organizations indulged much more in altruistic behaviors, meaning those behaviors that are outside of my job description. I have to tell you, if there's any industry that is probably altruistic in our country, would be those of the nursing industry in healthcare. And so I would venture to say that to take a look at those behaviors, categorize them in your organization, and see where you're leaning to. Are you leaning more towards sticking to a job description, or are you leaning toward having more people trying to help others and to provide any kind of assistance that may be outside their job description?
Oh, that's a great point. Thanks. Here's another question. What are healthcare organizations not currently doing that they should be doing in order to engage nurses better?
I'll give that to you, Christine.
Sure. So I think there's a couple different things there. We need to make sure that, at a basic level, that there is adequate staffing, because when it comes to nurse burnout, nothing is going to increase burnout faster than having a nurse taking care of too many patients at once. And I personally have experienced that. It's terrifying. It's not possible, and I think it's very important that we keep an eye on the acuity of the patients and the level of staffing that is associated with that. Outside of that, I think when we talk about measuring nurses' performance, again, we really need to identify the difference between a skill and a competency, and identify, and have that conversation ongoing and more often than once a year. We need to make sure that our nurses are providing competent care, that our patient satisfaction is where it needs to be, and we need to make sure that we keep a very close eye on the pulse of the organization, not just once a year and retroactively trying to fix things, but on being on top of things as we move forward.
Great. That's really helpful. Okay. Here's a question that came in. Now, Tom, we'll throw this one to you. Why isn't there any discussion about the number of patients assigned and the acuity of the patients? It seems as though the discussions still revolve around the nurses to be more professional, more dedicated, and more high-performing.
That's an excellent question, and I'm glad someone asked it, so then we can address it. If you go back to the premise or the idea that we're asserting here in the beginning, is that the problem really isn't that we don't have enough people to be nurses and we don't have enough money to pay them. If you buy into that, meaning that if we had enough educators and we can get enough nurses out there, that there is every indication, at least as of now, because unfortunately we can't measure something that's not happening. But there's every indication that would suggest that if we had enough educators and we got those nurses out there and they gave them the right training and we could pay them, because the money is there as it pertains to that I don't believe that there would be too many patients. The reason that we have, and I said earlier, I gave us statistics from the JAMA in 2002 that suggests that a particular nurse, right, the more patients that she or he has to take care of, the risk goes up. If we had more nurses, that would go down. And so I don't think that the issue is that we have too many patients, is that we don't have enough qualified nurses to handle the patients. And patients, they're going to be whatever they are. So I don't want to get in a situation where it's like, well, the way we would solve that is by, eliminating patients and all that. And by the way, that was one of the premises. I think it was back in, again, I go back in the 80s where, and especially you see that in wartime, right? A triage model where you would sit there and you'd have two doctors. I mean, anybody who's ever watched MASH on TV, you would see, right? You'd have all these people coming in from the front lines. And you have two doctors, and the doctor would look at a patient and would say, they would go through three things, right? No matter what I do, the patient's going to live. No matter what I do, the patient's going to die. Or there is something I can do that moves the patient from almost dying to living. Guess what? Those are the ones that I would attack first. So I hope I answered that question correctly, and that's why we hadn't focused. Believe me, I would love to have a multi-hour discussion around all these topics. It's something that myself and Christine are very passionate with, but I want to make sure that I drive the point home that there is that is the bottleneck when it comes down to ability to service patients.
Yeah, and Tom, I think you're right. One of the things. Yeah, so what we didn't really focus on today so much is the organization's responsibility too, because obviously you need to make sure that your staffing is appropriate. You're not going to have those high performers or those super accountable nurses if they're working 16-hour shifts and unable to get a break and way overtaxed with the amount of patients that they have. That's kind of stating the obvious, but I think it's important to note you can't put the onus on the nurses to be super accountable if they're unable to just get through their shift and if they're staying for 3-4 hours afterwards to catch up on documentation. So I think it's very important that we keep an eye on that and make sure that the staffing ratios are appropriate for the care that needs to be provided, obviously based on the acuity of the patients as well. So I do think that was a very good point by the question brought up by one of the viewers. So I just wanted to point that out and say thank you.
Well, that's great. We're getting tight on time here, but let's try one more question. If you were to offer healthcare organizations one piece of advice to improve nurse engagement, what would that be?
Christine, go ahead and give one. I'll follow up.
One piece of advice to improve nursing engagement, I would have to say that, again, we have to make examples of those nurses that are doing a fabulous job. It's okay to make examples of them, to provide them with the recognition that they deserve. Not everybody gets a trophy when it comes to this, and we need to make sure that those that are providing the best care are the ones that receive that recognition, and hopefully that will encourage the rest of the staff, or at least, provide an example for them to try to emulate their practice on.
Great. Tom, did you have anything to add to that?
Yeah, that reminds me of a book that was written by comedian Adam Carolla, and he says that the demise of our society was the removal of the gym rope in the corner of the gym, right? When you were 7th and 8th grade, you had to climb the rope. And I remember I was a chubby little 7th grader, and I couldn't go up to the top of the rope, and all my friends were looking at me and made fun of me. So you bet on come 8th grade, I was able to go all the way up that rope with some hard work. I think when we talk about engagement specifically, I want to go back to a operational definition which suggests that engagement means discretionary effort. So what are those things that I can do to help nurses focus their discretionary effort into providing better patient care? And Christine makes a great point around recognition, around resources, and authority, hence empowerment to be able to execute. So that's how I would address that.
Well, that's great and very interesting. Thank you both for an excellent presentation. That's all the time we have today. I'd like to thank our speakers and our audience for joining us. Now, shortly, you'll receive an email with instructions to access the on-demand recording of this webinar, as well as answers to your questions. Thank you all for joining us. Have a great day.